Thank you, everyone. Now, our next speaker is going to talk about surgery for small cell lung cancer. He is Chifu Jeffrey Yang, Dr. Chifu Jeffrey Yang from Massachusetts General Hospital and Harvard Medical Center.
Great. Well, thank you so much for the opportunity to talk today. It's such an honor to be here. I am really, really excited, and I was here last year, had such a wonderful time, and this Small Cell Lung Cancer Summit is incredibly inspiring. All the stories that I've been learning from every one of you have been really inspired. Today we'll talk a little bit about surgery for small cell and then also about lung cancer screening. These are my disclosures. So small cell is personal for me. This is my grandfather and my grandmother, and this is right after he became an American citizen, but just learned so much from him, and he was a big reason why I wanted to be a doctor. But unfortunately, he did get small cell, and it was discovered early, and I think it was probably operable, but it was not offered at that time. And so we'll talk a little bit about the latest guidelines, which do recommend surgery for people with early stage small cell. And these are the National Comprehensive Cancer Network guidelines. And what you can see there, that first sentence, patients most likely to benefit from surgery are those with early stage. So this is small cell that hasn't spread to the lymph nodes. And they also talk about how you need to make sure to evaluate the lymph nodes with different types of procedures like mediastinoscopy, and that even for people with bigger types of small cell, for example, T3. So these are small cell lung cancers that may be up to 7 centimeters that surgery could be considered. Now, it's really important. You still have to talk about it very carefully with the entire team. So the radiation oncologist, the medical oncologist, the patient's family. But I think guidelines have certainly changed. And this is a study that I did about 7 years ago. I was actually here at Duke for a residency, so in the North Carolina area. And what you see here are two curves. This is from the National Cancer Database, so a national US analysis. And the blue line is the curve for surgical patients, and the dotted red line is the curve for patients who got chemotherapy and radiation. And you find that the patients who got surgery did better. Now, granted, this is not a randomized trial. This is looking backwards. This is looking at data that already exists. But what this at least shows you is that patients who got surgery did well, did better than what we had previously historically expected. Now, the types of lung cancer resection are split into these three categories: a wedge resection, which is taking out a little bit of lung, segmental resection, which is taking a little bit more lung, and then a lobe, which is taking out a full section of the lung. I didn't put down, the other type of operation would be a pneumonectomy, which is where you take out the entire lung. And I don't think anybody here in the US is doing pneumonectomies for small cell, or certainly they'd be very rare. So we'll just talk about these three. In terms of the lung anatomy, there's different, you see on the right side there are 3 lobes. So there's the upper lobe, middle lobe, and lower lobe, and on the left side there's the upper lobe and the lower lobe. And I think everyone here knows this anatomy. The picture on the right breaks it further down into these different segments. So blood vessels and airways go into these individual segments and areas. And so and that's what we're going to talk about in terms of the types of operations you can do. A wedge resection is removing a slice of the lung or a rim of normal lung. And this is the quickest kind of lung cancer operation that we do. It usually has just a one-night hospital stay, and it's relatively rapid recovery. The limitation is that you don't get as good of a lymph node sampling. And so usually for small cell lung cancer operations, we generally try not to do the wedge resection, but sometimes you could still do it, especially if the patient's lung function isn't that good. And this is what this might look like in the operating room. You see that there's an instrument grabbing the lung and then a stapler that cuts and also staples the lung to seal off any air leaks. And there's a diagram in the middle, and then on the right is what it looks like actually in the chest. In terms of a segmentectomy, this is where you take out a little bit more lung, where you have blood vessels and airways that actually go into this section of the lung, and that's what you call an anatomic segment, where these actual structures are going into the lung, and you try to remove and divide all of those structures, as you see there on the right. And this operation does allow for a better lymph node dissection. And I probably, in terms of the smallest operation we would recommend for small cell, it would be this one. The most common operation we recommend for small cell, though, is the lobectomy. And this is removal of the entire lobe that contains the tumor. And the positives for this is that it definitely gives you the best lymph node dissection and most complete operation, but it's a larger hit to the physiological reserve. And so it takes a longer time to recover, and that's because you remove more lung. And this is what it might look like in the operating room. So you have, for example, this is a picture in the middle, a picture of the right lung, and you see that the upper part is the upper lobe, the middle lobe is on the right, and then the lower lobe on the bottom. And there's different branches of blood vessels and airways that go to the different sections. And so the picture on the right is you see the instruments dissecting out the airway going into the right upper lobe, and on the right lower part is after you divide that. And you can see that there's a lymph node right there in the middle that you can also get. And so after you dissect out all the structures, you're going to then complete the operation by dividing across the fissures, which is a natural border between the lobes, which is what you see there in the middle. And then I put a picture on the right where this is what this might look like in the chest, where you're dissecting out the different structures, where it's, I don't know if you can see that letter that says A2, but that's a arterial segment that's going up into the right lower lobe, and you see that instrument, that metal instrument, where we're dissecting across that. I will say, even though a lobectomy is a bigger operation, in this day and age with minimally invasive surgeries, the length of stay usually is about 3 days. So patients still do very well from this operation. We talked about lymph node dissection, and this is important because it helps the medical oncologist and radiation oncologist figure out what kinds of treatment to give after surgery. And this is a key part of what we do, is make sure we also take the lymph nodes after surgery. And so this is what that can look like. So picture on the left, you see those black little spots there. Those are the lymph nodes. And a picture on the right is after you take out the lymph nodes and you clean out that area. So in terms of minimally invasive lung surgery, this is something that most US thoracic surgeons actually do now. And one type is called video-assisted thoracoscopic surgery, that's VATS. And you see the long, thin instruments that go in and take out a section of the lung. And another trend that is becoming increasingly common is using the robot to help with that. So the robot usually has about 4 arms, and the surgeon sits at basically at what you call the console. And it's a little bit like playing a video game. And so the people have studied this, but surgeons who played a lot of video games when they were growing up, apparently this comes much more naturally to them. And this picture on the right is, you can see what it looks like in where the instruments are dissecting across some of the vessels. In terms of minimally invasive lung surgery, so I show a picture of the minimally invasive approach on the far left of the screen, and then you see the traditional approach, which is the bigger incision, and you have to spread the ribs in order to get a view. And it's obviously smaller cuts is better in terms of less pain, faster recovery, and fewer complications. That said, even with the open approach, the traditional approach, this day and age, people still also do really well. They usually only stay in the hospital one extra day compared to if you just did it with the minimally invasive approach. And that's because we figured out how to get patients better pain control, for example, with epidurals and pain medicine, and to get them recovering faster after surgery. So in terms of the postoperative course, it's about 1 to 3 nights in the hospital and 2 to 4 weeks of recovery at home. And patients usually can start getting back to work about 4 weeks later. And then we have to review the final pathology report and continue to survey. In terms of treatment after surgery, so this is a study that I did also when I was a resident at Duke, where we looked at patients who got therapy after surgery and patients who got therapy and patients who did not get therapy after surgery. And the red line shows the patients who got therapy after surgery, and it's better. The curves are separate. And over here, we further broke it down with getting chemotherapy, which is the chemotherapy and prophylactic cranial irradiation, which is the green line, and the red line is just chemotherapy. You can see that those curves are higher up, and they represent that patients did better when they got treatment after surgery. One trial that we're currently starting right now is this adjuvant chemotherapy and immunotherapy for completely resected small cell lung cancer. And this is the study that I'm leading, and hopefully it will be open in June. It's taken a little bit of time to get it open. So I remember last time I talked to you about this, I thought it would be open last year, but finally I think we're about ready. And so these are patients who have gotten T1 to T2 tumors and N0 to N1 tumors. So basically earlier stage small cell, and afterwards, if they got surgery for this, they can get chemotherapy and immunotherapy. And we're hoping that this study can wrap up fairly quickly. I know that there are several different centers, and Duke is probably going to be part of this as well. So the adjuvant regimen is going to be chemotherapy every 3 weeks for 4 cycles, followed by immunotherapy once every 4 weeks for a total of 1 year. And then the immunotherapy agent would be durvalumab, and then chemotherapy would be what we've talked about today and yesterday, just folks getting cisplatin or carboplatin and etoposide. So switching gears a little bit, another area that I work on is in lung cancer screening for small cell lung cancer. And from a research perspective, we've looked at this. And this is not published yet, but these are our preliminary findings, which is that we think lung cancer screening is associated with earlier stage diagnoses and improved survival versus small cell lung cancer. And this was a national analysis of 11,000 patients with small cell lung cancer from 2015 to 2019 in the SEER Medicare database. And 478 patients were diagnosed with small cell lung cancer after lung cancer screening. And what we found here, the picture on the left, you see a beneficial stage shift. So in terms of, you see the yellow arms are the not screened arms, and the blue arms are the screened arms. And what you'll find is that there are more patients in the localized, in the earlier stage, if they got the lung cancer screening. And this also translates to survival benefit that you see in the middle of the figure there. And we had to control for different variables and made sure to try to make this as rigorous of analysis as possible. But so far it looks promising. So we're excited to share that with you, and hopefully we can get that paper out in the next couple months. The other types of lung cancer screening that I do is I currently try to study whether lung cancer screening can be expanded to people outside of the USPSTF guidelines. We had heard this powerful story from Wendy today about how her lung cancer screening got started early, even before when it was recommended. And that's what I'm trying to do, is study that as well, to see if we could offer lung cancer screening for more people. And we started that study, and this is Bertie Gethers, who allowed me to share her information with you all. And she is part of this study where she really didn't smoke that much. You saw that she only smoked 3 cigarettes a day, but she did smoke for quite some time, but just simply did not meet the USPSTF eligibility criteria. We were able to screen her, and we found 2 lung cancers in the right upper lobe. And so I took out the right upper lobe for her earlier this year, and she's doing really well. So, and she's actually been part of lung cancer advocacy for us ever since. The last thing I wanted to share with you a little bit is the work that I do in community outreach through the American Lung Cancer Screening Initiative. We try to raise awareness of lung cancer and lung cancer screening, and to increase access to lung cancer screening among high-risk individuals. And this is something I showed last year, but I think it's important to show again, because I really believe that if you tell people about lung cancer screening, they will get screened. But this clip just reminds us all that, and let me see if this works, reminds us all that oftentimes people don't get that message in the news.
To cancer screenings, I want to say anybody who really needs them needs to call today, because it could take months to schedule an appointment.
My sister-in-law over Christmas holiday just told me that it's basically a 10-month wait for her colonoscopy.
Yeah.
10 months.
I waited 8 months to get a mammogram appointment for this week, but it's my first one because I'm in that age group now.
Correct. So screenings are so important because we have great treatments for cancer, but you got to get to things early, right? So let's talk about the 4 most important ones that we focus on. So cervical cancer, you can see for women, should start around age 25 with an HPV test or Pap test. Breast cancer screening. So women should have the choice to begin annual mammograms at age 40. Absolutely by age 45, they should be doing their annual mammograms. Colon cancer, for those who are at average risk, usually you start your colonoscopies at 45 or above. And then last is prostate cancer. You can talk to your doctor about getting screened once you're over 50, but if you're African American, or if you had a family member who had prostate cancer, father or brother, before 65, you might want to start screening earlier. And again, all of these depend on really your own risk too, and your family history.
And that's the entire clip. So I didn't cut anything out. And so it's really important for us to get out there in the community. And that's what I've been doing for the past 8 years. So this is when I first started. The picture on the left was me at a church, and then just going out there in the community. And my family, I put up there because they frequently join me on these lung cancer screening outreach events. We were out there at the Cupertino City Council, and the picture on the bottom is me and my wife and our team with the mayor and the city council talking to them about lung cancer screening. So it's since expanded to just beyond me and a couple students to now over 500 students across many different chapters, where we're trying to raise awareness and try to get people screened. And now we have 102 chapters. Last year, at this point, we had 70 chapters, but now we have 102. Still working really hard to try to get a chapter in High Point started. So, but hopefully soon. But we have Duke University and UNC and NC State, actually. So great representation from North Carolina here. And these are just some pictures. Some of you may know Alex Potter, and that's her in the right next to the bear. This is a picture from Berkeley. And this is a picture recently from us at the National Lung Cancer Roundtable with some of our student leaders. And what we do is we go out there in the community, we teach people about lung cancer screening at health fairs, campus events, canvassing at bus stops and subways, tabling at community events, at food pantries, at parks, and white ribbon builds, and then also some virtual presentations. And we've been fortunate to get a welcome reception. So for example, in Boston, this is one community member saying that these are the only people who will ever come and tell us about this. And another person from Houston said, I had no idea about lung cancer screening, and I've smoked since I was a teen. And then from Chicago, please come back. Everyone needs this message too. This is the white ribbon relay, and I'm excited to share with you that we were able to complete this. We basically had 4 white ribbons start from the different chapters across the US, and then had them converge in Colorado. I'll just show you a quick clip. It started off, this is one of them in Boston. With Heidi and David Carbone in Ohio. and then actually arriving to Colorado, which is great. So we're really excited that we're able to get those white ribbons in and actually arrive on time. So, and I appreciate a lot of folks here, because I think that there are folks here who had supported that as well. Another initiative we're trying to do, we're just trying to figure out innovative ways to get the message out there. So one way is to get the announcements about lung cancer screening in stores, and so that people can see. And so this was us in Fitchburg, which is about an hour away from Boston, and Fitchburg had basically gone through some tough times. GE had left, and there are a lot of folks who do smoke there, and there's not much information about lung cancer screening. So that's why we decided to go there. But for example, this was at Fitchburg Variety, and my wife and I, we put a lung cancer screening sign right next to the ATM there. And then Maggie put lung cancer screening information right at the front desk. So if you had to have, you will see it for sure. Lung cancer screening may save your life, and information about that. And then in Newton, we started expanding this out to different cities. So this was in Newton, and you see the lung cancer screening may save your life poster, again, right at the cash register. And then another shop where it's right at the cash register. So I'm really excited about that. And then I'll close with the last thing we've been doing is just trying to get these announcements about lung cancer screening when we're flying. So this is one of our students, Sonish, and he's actually only in high school, and he's probably the bravest one of us all. But I wanted to show you a couple of these clips.
Ladies and gentlemen, did you know that lung cancer is the leading cause of cancer-related death in the United States? But it doesn't have to be thanks to early detection through lung cancer screening. So if you know anyone over the age of 50 who has a history of smoking, please tell them to talk to their doctor about lung cancer screening today. A quick scan that lasts 5 minutes and is covered by most insurances can save your life. Thank you so much and enjoy your travel.
So I don't know, could you guys hear that? Okay, good, sorry. So I was just really impressed that he did it. He continues to do that on every flight that he is on right now. And so, and we're trying to do that. As you know, Heidi, we got the idea from Heidi, because Heidi tries to do that as well. This is Alex Honnold. Does anybody know Alex Honnold? Okay, so he is rock climber, and he's well known for free soloing El Capitan, which is this really big mountain in Yosemite. And because most of the time, when you climb these big mountains, you have to have ropes and a lot of support. But and sometimes it takes folks 4 or 5 days to get up the mountain. But he did it just with his bare hands, just like this, and and he did it in 4 hours actually. So it was really impressive. Anyways, so I was, as Dusty was alluding to, I was at the American Association for Thoracic Surgery conference in Seattle, and I just flew back. And he was our keynote speaker. Every year we have a keynote speaker. Last year it was Arnold Schwarzenegger, and this year it was Alex Honnold. But I think that us as a community, we need, and by community I mean us thoracic surgeons. I'll just speak for us in thoracic surgery. We need to try harder to figure out ways to get public leaders involved. And last year with Arnold, I felt a lost opportunity, because it was basically an entire hour hearing him. It was a fireside chat, but it was an entire hour hearing him about his bodybuilding and movie career, and then his political career, and that was it. And no opportunity to, or no effort was made really to ask Arnold if he could advocate for lung cancer screening. And so, this year we tried to do something a little bit different. And so you can see Sonish is back on stage here.
And I really helped to raise awareness about Ewing sarcoma. So right now in the U.S., so few people are getting lung cancer screening. Less than 20% of people eligible are getting screened for lung cancer. And so my question to you is, can you help us with lung cancer screening?
Honestly, I know almost nothing about it. I'm like, maybe. No, I can't. I mean, I'm happy to learn more about it.
Awesome. Also, how many quotes did you do?
I don't know. Many.
Thank you so much.
Yeah, thank you.
Alex?
Great. So I don't know if you quite caught that, but basically, Sonish got up on the stage, on the microphone, and first, thanked Alex for raising awareness for Ewing sarcoma, right? Because Alex Honnold had gone rock climbing with a 17-year-old cancer survivor to raise awareness about Ewing sarcoma. And then Sonish asked him, told him, lung cancer screening, nobody is doing it in the United States, or very few people are doing it. And then he asked Alex, can you help us with lung cancer screening awareness? And then, the first thing Alex Honnold said was, I don't know anything about lung cancer screening, which is unfortunately still true in this day, is that many people don't know about it. But the great thing was afterwards, he said, in that same clip, he said, I would be happy to learn more. And after his talk, our entire team, I actually forgot to put that picture, but our entire team went up and talked to him. And so far, it looks promising that he's going to try to raise some awareness for lung cancer screening. So, yeah. Yeah. Great. Well, thank you very much. Yeah.
Thank you so much, Dr. Yang. One thing I want to tell everybody here is one thing I'm very proud of in my advocacy is last year I presented a white ribbon to the mayor and the council in my town. Not a big town, but it got some attention, and they signed a proclamation naming November as Lung Cancer Awareness Month. But what I wanted to ask Dr. Yang is about transplants, because we're now hearing more and more about lung transplants for non-small cell. Do you see that in the future for us?
Thank you for your question, and thank you for all that you do to raise awareness for lung cancer and lung cancer screening. I think that for small cell, so I agree with Dr. Shields, what she said yesterday. It's probably not on the horizon for transplant, and just because small cell has a tendency to have already been in different parts of the body other than the lung. And so I think that at least right now, it's probably, transplant is not an option for small cell. But I think with increasing developments of therapy and developments and advances in the field, it could be a possibility. I think never say never, so yeah.
I just have a question for you all. How many in this room have never smoked, but you're still sitting here? Anybody besides me? 2 of us. I love that we're all pushing for early screening, but they all talk about smoking and screening. I keep telling everybody, I know a lot of people over 50, if you're 50 or over, please insist on a low-dose CT screening at every one of your checkups. And I'd like to see others in the community that are pushing for this to include non-smokers in the screening process. Thank you. Thank you so much for your presentation.
Yeah, thank you for your comment. I think that it's so important for us again, I'll just speak on behalf of only thoracic surgery because I'm a thoracic surgeon, but for us to really figure out how best to screen not just folks who smoke and meet the guidelines, but also people who are not currently eligible to get screened under the current guidelines. It's just the screening guidelines right now is just simply way too restrictive. Every year about 250,000 Americans are diagnosed with lung cancer, but only about a half of them are actually eligible to get screened for lung cancer. So that tells you essentially 125,000 Americans every year get lung cancer and never was eligible and never got the potentially life-saving screening. So we just have to do much better as a field. And in that regard, there are several of us who are trying to figure this out and do research in this area, but it just takes time, which is but we're trying to move fast on this. So, yeah.
I just wanted to reemphasize this, that, the information that Dr. Yang showed you about the benefits for limited stage small cell patients to have surgery, this is not common knowledge, okay? You guys are insiders to get that information before it's even published. But so just know that when you talk to your medical team, they may not know this. And so, as it becomes published, we'll share that with you. In fact, I'm going to put you on the spot, Dr. Yang, and ask you to speak to our virtual group about surgery sometime in the near future, hopefully. But anyway, so just keep that in mind that, surgery may very well be an option for you. Any questions for Dr. Yang?
To do surgery on certain people, how do you know which ones you do and which ones you don't?
That's a great question. Are you asking how do you know when to do surgery for certain folks? So right now, if the small cell is really in its earliest stage, so it hasn't spread to the lymph nodes, then and it's small, then we would recommend surgery. And at Duke, that's where they, at Duke and UNC and Wake Med, they would definitely recommend it, and so would us at Mass General in Boston. The one thing I will say is that, with the increasing use of lung cancer screening and also the increasing use of CT scans, we are finding more and more small cell lung cancers that are small and that are in the earlier stages. So this past year, I've done 2 operations actually for very early stage small cell lung cancers.
Thank you, Dr. Yang. I fit into that category, early detection surgery. I thank you for advocating. I just got on board with my thoracic surgeon at Northwestern Hospital in Chicago, and he will be making some steps and contacting those that he knows that will advocate more for lung cancer, and I am just so grateful. So thank you for just moving forward with this. Thank you.
Thank you.
Very much, Dr.
Great.
Yang. I know
Great,
you have a
thank you.
flight to catch. Thank you so much for sharing with us today.
Great.
And I'm going to turn it up to Montessa now.
Thank you.